still, there was also the risk that the biopsy missed the target or the tumor initially. So prostate MRI was only recommended if the biopsy showed no cancer despite a continuous risk of having cancer. So there was the risk of upgrading or downgrading at prostatectomy, but the persistent risk of missing the cancer in the biopsy initially. And all this changed in 2019 after some signature trials has been conducted. For example, the Precision or the Promise study published in Lancet and the New England Journal of Medicine, which introduced the pre-biopsy MRI, illuminating the targeted lesion, which was then able to target directly through the biopsy. And this allowed for an increased detection rate of clinically significant prostate cancer defined by the grade group 2 or larger, which we will discuss in a minute, and reducing the detection rate of low-grade prostate cancer defined by a grade group 1. But the question is, why is MRI good in detecting aggressive prostate cancer, and how do we achieve standardized reporting? So let's start from the basics. Well, prostate cancer is not the same, as I said in the beginning. Not every diagnosis is the same. So the diagnosis is based on the histology, which is retrieved by the biopsy. And we want to diagnose the clinically significant diseases, which is defined by a Gleason pattern 4 and 5. And this Gleason pattern 4 and 5 is also grouped then in the Gleason score and the International Society of Uropathology, which grouped those into a group from 1 to 5, and every group larger than or 2 and larger is defined as clinically significant prostate cancer at the current stage. This is also a topic which is dynamically discussed. But MRI is really able to detect aggressive cancers, which has shown in the early years of the 2010 to 2015, where we can see that there is a distinct variance in the signal intensity and diffusion weighted imaging depending on the aggressiveness of the cancer, as shown in these box plots with the high grade, intermediate grade, low grade, and normal prostate tissue, all with significant difference. So there is hope that diffusion weighted imaging can really detect those lesions. And the question is, why is MRI able to do that? And for that, we have to jump in the histology. So diffusion weighted imaging is based on the diffusion and movement of water molecules. The denser the tissue, the less the molecules can move, and we have an increased restriction. On the left-hand side, you can see the normal prostate tissue with an architecture of the normal prostatic glands, fibromuscular tissue. So this is the typical prostate tissue you expect. On the right-hand side, you can see already a diagnosis of prostate cancer, however, a low-grade Gleason 3 lesion, where you, on the first glance, at least for me as a radiologist, you don't see a distinct difference. Again, you see glands, you see fibromuscular tissue, so the image impression might be identical. In fact, when we look at an aggressive prostate cancer, as shown here with a Gleason 5, so the most aggressive type of cell growth, and if we magnify those cells, we can see that the architecture is completely destroyed, cells are very dense and packed, and we can reason that here we have a severe restriction of movement of water molecules, so a diffusion restriction. And here are 2 cases who show for it. In the upper bar, you can see on the left an aspect of the prostate, a mildly T2 hypointense lesion correlating to a mild diffusion restriction in the ADC map and the diffusion weighted images. Comparing to the lesion in the lower row, you can see that this lesion is really markedly hypointense in T2 weighted images with a distinct and marked diffusion restriction in the diffusion weighted images and ADC, and histology proved that the upper row was a low-grade prostate cancer and the lower bar was an aggressive cancer. So here we now know that aggressive cancer correlates with a high diffusion restriction and a more marked hypointensity on T2 weighted images. But how do we report those images in a more standardized approach? And here we can use the PIRATES criteria, which exist in the version 2.1 published in 2019, which allow us to conduct MRI in a standardized approach interpret imaging findings in a standardized approach, and then also prepare a report for the urologist or general practitioners to make the results more generalizable and also understandable. So there are three key signatures, three key sequences we have to conduct in the MRI. So the first step is a T2 weighted image. It's a high resolution T2 weighted image, at least in two planes, so an axial and coronal or sagittal image. Then diffusion weighted images, importantly with a high calculated b-value, normally around the b-value of 1,200 up to 2,000, which is normally more used in a screening setting in experimental studies. But again, a high calculated b-value is essential for accurate diagnosis. And then in a multiparametric MRI approach recommended by the PIRATES protocol, you use intravenous contrast media to acquire the dynamic contrast enhanced sequences to look at the perfusion of lesions and the prostate. And then we are able to score lesions on the scale from 1 to 5, assessing the probability of clinically significant prostate cancer. And as you can see, we can also score a very low to low probability with a score 1 and 2. And this, in fact, is a topic we really investigated in the Prokomb study, because in the years where the signature trials were on the way, mainly focusing on targeted biopsies and the cancer yield, urologists and everyone was wondering, what should we do with negative MRI, and should we perform a systematic biopsy? So the Prokomb study was initiated with two objectives. First, is it safe to omit biopsy following a negative MRI despite a clinical suspicion for cancer? And is the MRI pathway really feasible in an ambulatory care setting, or only feasible at a high-volume expert center? And these two objectives were assessed. So the Prokomb study is a prospective, multi-site, longitudinal cohort trial, recruiting men from 2016 to 2017 in Berlin in 54 community-based urology centers, and we recruited 607 men with clinically suspected prostate cancer and no previous biopsy, which were then recommended to undergo MRI at two imaging centers at the tertiary center here in Berlin, where we used the PIRATES protocol version 2, so version 2.1 was not yet published. So we used PIRATES version 2 in consensus readings and 3 Tesla MRI, assessing images, for example, shown on the right-hand side. In this case, a PIRATES 4 lesion with a T2 hyperintense nodular lesion on the right aspect of the prostate, with diffusion-weighted imaging and restriction, and also a hyperperfused lesion in the site, so a typical PIRATES 4 lesion. And based on those images, men were then stratified in either a negative MRI, defined by a PIRATES score 1 to 2, which were then recommended not to go under biopsy, instead to undergo active monitoring for 3 years with regular checkups and a follow-up MRI or biopsy if clinically indicated. And MRI positive men were defined by a PIRATES score 3 to 5, which were then obviously recommended to undergo targeted and systematic biopsy in a cognitive or MRI fusion approach. And those men with no cancer at biopsy were also recommended to undergo follow-up for 3 years. So this cohort showed men on average with the age of 64 years and slightly elevated PSA of 5.8 nanograms per milliliter, a slightly elevated PSA density of 0.14 nanograms per milliliter, and a prostate cancer or a clinically significant prostate cancer prevalence of 29%. And those characteristics are comparable to other key signature trials in the last years. So results are assumed to be generalizable among different countries and cohorts. When we looked at the imaging, we noticed that almost every second man with clinically suspicion of prostate cancer showed negative MRI findings, so no biopsy was recommended in almost half of the cohort. And this prevalence is slightly higher than the 1/3 MRI negative findings in the Cochrane analyses published in 2019, but again also comparable to other prospective studies such as the 4M trial or the MRI proper trial, which is more recent with a 55% MRI negative findings. Also, the radiologist did a good job in reporting the images with only a low prevalence of Pyrite 3 lesions. So Pyrite 3 is often also referred as a quality metric. The higher the Pyrite 3 rate, the more difficult is the interpretation of MRI findings. So with a 12% Pyrite 3 report rate, the quality was very good in the MRI reporting. And now the question, is it really safe to avoid biopsy in almost every second man despite the clinical suspicion of prostate cancer? And the answer is yes, at least in the Prokomb study, with only 4% clinically significant prostate cancers after 3 years, and only 15% underwent additional MRI, defined here by a follow-up MRI, and only 14% underwent biopsy over those 3 years. So we were also avoiding biopsy in a large number of patients. So the question is, why do those men have an elevated PSA if there is no cancer? Well, we know the answer. Also shown in the image, it is the benign prostatic hyperplasia, so the enlargement of the transition zone, which then increases the PSA level, here in this case up to 12.5 nanograms per milliliter. And here you can see the extent of the prostate in this patient. Again, the PSA density is useful to incorporate in your decision making. So after 3 years, we were able to demonstrate that the MRI has a negative predictive value for clinically significant prostate cancer of 96%. Biopsies were avoided in 41% of the total cohort, and 86% of MRI negative men did not undergo biopsy over 3 years. And overall, the MRI negative men showed a very low rate of clinically significant prostate cancers, comparable to the cohort of healthy screening men or men in a screening setting, and thus comparable to the cohort in the EP1 prostagram study published in JAMA Oncology 2021. But also we have to look at men with obviously positive findings at the MRI and see if the ambulatory care urologists with cognitive biopsy did a good job in detecting cancers, and indeed they did, with 98% detecting cancer in Pyrite 5 lesions, and overall a prevalence of clinically significant prostate cancer of 51% in MRI positive men, including Pyrite 3 lesions. So the performance was very good. In men with no cancer at biopsy, again, the follow-up was also conducted, and here we detected clinically significant prostate cancer in 7%. However, with a little bit more effort, so more men underwent follow-up MRI, not every third, but 1/3 of all men underwent MRI, and 20% underwent additional biopsy in this follow-up setting. So the question is this MRI pathway really feasible in ambulatory care? And we think it is. So 86% were biopsy free after 3 years, which shows a high acceptance of the patients and urologists and a trust in the MRI reports. So we were able to avoid biopsy in a large proportion. And patients completed the follow-up in 84%, so patients were able to show a high adherence to the safety net approach and the monitoring. And finally, only 15% of MRI negative men underwent additional MRI. So again, there was not a substantial increase in costs and monitoring measurements, so it is also feasible and sustainable in a follow-up setting. But as I mentioned at the beginning, we are expecting a surge in prostate cancer cases and men with the risk of having prostate cancer due to the demographic change in our society, and we have limited MRI capacities and at current stage in insufficient risk stratification. As shown again, every second man was MRI negative, and the PSA was identical between men with a positive and negative finding. So we will have to work on more risk-adapted MRI and biopsy decision-makings, really implementing innovative biomarkers, for example, polygenic risk scores, PSA density, and also AI for an improved risk stratification to make the whole process more streamlined And also we have to think of a more structured monitoring recommendations. There has been an update last year in the EAU guidelines, so the European Association of Urology updated those guidelines, but we have to think not only about men with a negative MRI, but also those men with a low risk before MRI and those with a negative biopsy after MRI showed a targeted lesion. So we need recommendations how to perform the monitoring, for how long, to really guide the patients and us in the decision making to assure the safety of the patient. So in conclusion, the Prokomb study was able to prove that the MRI-informed biopsy decision-making is oncologically safe. The MRI allows for targeted biopsies with a high detection rate of clinically significant prostate cancers, and the MRI pathway is also feasible in ambulatory care, including an active monitoring approach, but also only if the image quality and the reader experience is assured. This is really key aspects for good MRI reporting. But in the future, we will have to work on risk-adapted decision-making to really enhance the availability, efficiency, and accuracy of this MRI pathway, which is promising for the future. Thank you so much, and I'm looking forward to the opinion of the urologists and the discussion.
Super. Thank you so much, Charlie, for your fantastic presentation and for sharing all those insights and the results of the Prokomb trial. And I've seen that several questions have been submitted in the chat already, so thanks for submitting those, and please keep doing so. We have a discussion in the end, 15 minutes to address the questions, and I will now hand over the microphone to Professor Hinz, who will provide us with the urologist perspective. So stage is yours, Stefan.
Yeah, let me first share my screen. Do you see everything?
Looks good, yeah.
Great. So thank you very much, Laura, for the introduction, and it's a great honor for me to participate in this really international meeting. And my job today is to give you the urologist perspective of the MRI and the value of the MRI in decision-making for localized prostate cancer. And as we have heard before, that the MRI is getting more and more important in the decision-making, and of course it's based on a very good quality that we have today. Let me show you my disclosures. And the agenda today is that I would like to go into the details of medical indication for prostate biopsy. Let me show you a little bit what the EAU guideline tells us. Then I'll go into the difference of the systematic versus the MRI fusion biopsy, and go even more into the details of the transrectal and the transperineal approach of the prostate biopsy. And then we go into the clinical decision, and we're comparing active surveillance versus definite therapy, and the decision-making for surgical therapy. I would like to start with a case. This is a 75-year-old patient, symptom-free, no significant underlying diseases, and he does not have a family history of prostate cancer. He has a PSA value of 5.2 nanogram per mil with a free PSA proportion of 20%. He has an enlarged prostate with 59 milliliters and a PSA density of 0.09 nanogram per milliliter square. The digital rectal examination did not show a palpable tumor, and the patient already has undergone MP MRI, and this shows one Pirates 3 lesion. So who would perform a biopsy in this patient? I think it's quite hard to say. This patient has not really given us a real clue if we should or have to perform a biopsy or not. So let's go into the risk classification of this patient. So I think the most important thing is that we have to see how is the life expectancy of this patient. He's 75-year-old and no underlying diseases, so he has a good life expectancy, which should be at least 10 to 15 years to proceed with any further diagnosis. So this is given in this case, so I would not exclude a biopsy for this patient. So one of the most important risk factor also is if he has a palpable tumor, so the digital rectal examination is still important. He has no palpable tumor, so no hint for a biopsy. The PSA value is 5.2 with a free PSA proportion of 20%, which is right in the middle. So if we have below 15%, we would suspect a prostate cancer. If we are above 25%, we would more suspect a benign lesion. So he's right in the middle, so no real or clue to make a prostate biopsy or not. He has an enlarged prostate, so his PSA density is 0.09, so it's quite low. It's below 0.15, so more or less suspect for a benign lesion. And I don't have to tell you about the Pirates 3 lesion. As you all know, this is no real indication. In the Prokomb study, we have biopsied those patients, but in real life, it's not a hard indication to do a biopsy. So I think it would be reasonable to follow this patient and just follow his PSA value and see how it develops clinically. So what do the EAU guidelines tell us? So they have a flow chart, which is quite practical to use. It's a diagram for deciding on prostate biopsy, and they start with the life expectancy. So we do need a life expectancy of at least 10 to 15 years, as I said before. And then they go into the initial risk assessment. So PSA value, PSA density, digital rectal examination, family history, and if he has an intermediate risk for prostate cancer, not a low risk, then they already recommend an MRI. And of course, we have to discuss this later on. The availability of a good multi-parametric MRI is not given in every country, not in every city, and we also have problems in Germany to get a good NP MRI, and we have to discuss what we have to do if it's not available. But at least if it's available, I would recommend it in this stage before the biopsy. So up to date, I would not really recommend a biopsy without an MRI, except for those patients that have a clear risk for prostate cancer with a PSA value of above 50 or a T3 or a T4 tumor. Of course, those patients probably don't need an MRI. We can just proceed with a systematic biopsy. Going more into the detail for the indication, so if we have an MRI, then I think the PIRATE score is the most important risk factor for prostate cancer. So with a PIRATE score of 4 to 5, we have a 62% risk of having a clinical significant prostate cancer, so with a Gleason of at least 3+4. And therefore, I would recommend for every patient with a PIRATE score of 4 to 5 to perform prostate biopsy. Same goes, or the second biggest risk factor is the PSA density. We heard it before in the talk of Charlie Hum, that the PSA density is getting more and more important, as do other risk factors. But this risk factor is included in this EAU guideline, which is quite new from 2025, and they divide 4 different risk categories. So the low risk group has a PSA density of below 0.1. The intermediate low risk group has a PSA density of 0.1 to 0.15. The intermediate high risk group has a PSA density of 0.15 to 0.2, and the high risk group has a density of 0.2. And all those patients with the high density, of course, I would also recommend a prostate biopsy. And in the middle of those groups with a PIRATE score of 1 to 2 or PIRATE score of 3, and with the low, intermediate, or intermediate high risk density, we can look at the diagram and see if a biopsy is recommended or not. I think this is quite practical and quite handy to use. And unfortunately, the US guidelines do not have similar diagrams that can lead us. So let's go into the decision. If we have made the decision for a prostate biopsy, we still have to decide what kind of biopsy do we have to perform. And of course, we have the option of a systematic transrectal ultrasound-guided biopsy, which is, I suspect, still the standard in Europe and all over the world. We have a detection rate of 32 to 41%. And of course, since we do not see the tumor in the ultrasound, we have a high risk of false negative biopsies. And the second option, if we have the information of the MRI, of course, we should use it. And one form of using it is the MRI ultrasound fusion biopsy. We do have an improved detection rate with an increased detection of clinical significant tumors in plus 18%. So I think if we have the information, of course, we should use it. And Charlie Hamm stated it before, or elaborated on those publications. We do have 4 randomized prospective trials, and Lara Rodriguez Sanchez summarized it quite intelligent in this sentence. That included all the 4 landmark studies for the MRI and prostate cancer detection. For most, one can promise precision if you perform MRI first. And I think this says it all. We do need the MRI before the biopsy, and those information really help us to be more precise in the diagnosis. And why is the precision so important in the diagnosis? Because all the clinical decisions that we have to do afterwards are based on the correct diagnosis. So how should we perform a fusion biopsy? And we have heard that the cognitively fused truss biopsy is not that bad. So we do get good results, even especially in those cases where we do have a larger targeted field. And if we know where the tumor is, of course, the chance of hitting it is better if we know where it is. The second option is an MRI-guided prostate biopsy. It's an in-bore prostate biopsy, which is quite complicated. It goes through the gluteus muscle, and we do need long needles, and we do have one center in Germany who still does that. But I think it's not a standard, and we do have easier ways to get the information or the MRI information into the ultrasound picture, and this is the MRI ultrasound fusion biopsy. Just one example, we do have lots of machines who are able or capable of fusing the MRI picture with the ultrasound picture, and I think this is today probably the best way to include the MRI information in the ultrasound or in the biopsy. Of course, not everybody has this machine, so the second best alternative is the cognitively fused biopsy. And let me go a little bit more into the detail of the biopsy. So, of course, the standard is the transrectal approach. Even in Germany, up to date, it is an established technology. It's easy to use. Everyone knows how to do it. And of course, we're able to do a fusion biopsy transrectal and transperineal, which is the alternative. It's an uncomplicated outpatient implementation here, but we do have post-operative infections, and we do need the perioperative antibiotic prophylaxis. And of course, we do have a poor image because the patients don't like the approach through the rectum, and therefore we have the alternative, the transperineal approach of the biopsy. So the perineum, of course, it's much easier to disinfectate, and we do have, which is the main advantage of this technique, we do have hardly any post-operative infections. And of course, we have to discuss if we do need a perioperative antibiotic prophylaxis. But on the downside, we have higher technical efforts. We do need this machine, which is quite expensive, costs about 150 to 200,000 euros. And we do need, or most of the hospitals do need a general anesthesia. So we in our hospital, and we also established this method in quite a few hospitals in Germany, we have established a pudendal block, which makes this perineal biopsy easily implemented in a local anesthesia. So I think it's good to make this as a standard, and actually we're not performing any transrectal biopsies anymore. So all our biopsies are done by the transperineal approach right now. We also performed a study. This is a prospective randomized controlled single-blinded interventional studies that we performed together with the group of Eduard Barko from Oslo. And we were able to demonstrate in more than 500 patients that the patients that have gotten a perioperative antibiotic prophylaxis did not have less infections than the patients that did not have an antibiotic prophylaxis. They were getting a placebo, and both groups did not develop a sepsis, and the urinary tract infections, or the frequency of urinary tract infections, was equally distributed, and there was no significant difference. And therefore, I think we have proven that the antibiotic prophylaxis is not necessary in the transperineal approach of the prostate biopsy. So how do I biopsy today? So at first I would check the indication. I think this is one of the most important steps. Then I would, if it's available, perform a multiparametric MRI first. Then I would prefer the transperineal fusion biopsy plus the systematic biopsy. And we also having the help of artificial intelligence right now. So we're using the Quantip system in every patient. So we're getting more information here with the artificial intelligence. And I think it's especially important for patients with the pirates 1 to 4 or 1 to 3 to get regions of interest that might show us a significant or clinical significant tumor. And we do not need the antibiotic prophylaxis anymore, which also is good for the general health in Europe. So we should use as less antibiotic as possible. So another case study here. This is a 73-year-old patient, symptom-free, no significant underlying diseases. He has a condition after transurethral resection of the prostate 2007, and his PSA value is rising up to 6.2 nanogram per mil with a free PSA proportion of 10%. He has a prostate volume of 43 mil and a PSA density of 0.14 nanogram per mil square. And the digital rectal examination did not show a palpable tumor. And I think this patient probably needs a prostate biopsy. So we did perform a MRI first. And this shows 2 Pirates 4 lesions as shown in the pictures, one in the peripheral zone dorsolateral right with the Pirates 4, and the second one in the peripheral zone ventral paramedian left, also a Pirates 4. We did not show any metastasis or extra capsular tumor in this patient. And these are the pictures of the MRI fusion biopsy. We do have a needle tracking system here, which is quite comfortable, especially to see retrospectively where the positive biopsies are. And we did show in the biopsy that we have 4 biopsies with the prostate cancer, 3 biopsies with the 3 plus 3 equals 6. With the tumor amount of 10%, and 1 biopsy with the Gleason 3 plus 4, and the Gleason 4 aspect takes 30% of the whole tumor. So what's interesting in this case is that the Gleason 3 plus 4 biopsy is outside the MRI targeted fields. And this is the reason why we still perform a systematic biopsy in all the patients, since we are able to detect clinical significant tumors in those patients even outside the Pirates lesions. And we're doing an adapted profile here. We always do 10 biopsies. And so the biopsies that have been taken in the targeted field are spared with the systematic biopsies. So therefore, we are not taking more than 10 biopsies, which is quite comfortable for the patients. And of course, we might be able to even spare more of the systematic biopsies with the help of artificial intelligence, but up to now, we are not there yet. So we're doing systematic and targeted biopsies altogether. So if we have the results of the biopsy, we have to decide for this patient what's the best therapy for him. And of course, if we did not have the 3+4 lesion, everything would be clear. This would be a clear patient for active surveillance. But we do have an intermediate risk tumor here. And so we have to decide if he's still available for the active surveillance. So at first, we have to decide active surveillance or watchful waiting. And watchful waiting is, of course, a palliative treatment. So with the watchful waiting procedure, we do not have a predefined schedule. We just follow the patient specifically. With the active surveillance, we have a curative approach with a predefined schedule for the patient. So the PSA value has to be repeated, and also the MRI or the biopsy has to be repeated. And let's see what the guidelines tell us. First, let's have a look of the risk of the patient. So we have lots of risk calculators, and this is just one example. There are others of the MSKCC and so on. So I put in all the clinical details of this patient, and what this predict prostate risk calculator tells us is we have to also choose the therapy of if conservative or radical. And from 100 patients, he tells us how many patients will die due to other causes, and this is 55 in this setting. We have 36 survivors with initial conservative management, so those patients would have been lived no matter what kind of therapy we choose, conservative or radical. And we have 5 extra survivals due to the radical treatment. So those are the ones that really benefit from the radical treatment, may it be radiation or surgical treatment. And we do have 4 prostate cancer related deaths, even though we are doing a radical treatment. So I'm not a huge fan of those risk calculators because they are just based on survival. And I think it's quite important that we also have a look at the quality of life. And if we have recurrent prostate cancer or a metastatic prostate cancer, and we have to treat those patients with hormonal therapy or chemotherapy, of course, we have a lack of quality of life. And therefore, I think it's really important to not just look on survival, but also on the quality of life. And that's something that is not calculated in those risk calculations. So what do the AUA guidelines tells us? Is quite old, from 2022, and I'm not a huge fan of the AUA guidelines as well, because it just gives single recommendations. And for these patients, we really cannot handle the information. What do they tell us? For patients with favorable intermediate risk prostate cancer, clinicians should discuss active surveillance, radiation therapy, and radical prostatectomy. So this recommendation really doesn't help us in counseling the patient. And therefore, I think we have to use other guidelines, and especially for those patients that have a favorable intermediate risk, it's quite hard to counsel those patients because the guidelines are not very conform in their recommendation. For all the patients that have a low risk tumor, I think the recommendation is clear for active surveillance. So those are the ones with a Gleason score of 3+3 = 6, a clinical stage CT1 or CT2A, a PSA value of less than 10 nanogram per mil, and the PSA density of less than 0.15. I think then with those patients, we are totally safe to go for active surveillance. And for the favorable intermediate risk, it's quite hard to define those patients. So we have a definition of the Canadian consensus group and the ASCO, and they are similar in the recommendation with CT having the tumor clinical stage less or equal CT2A, a PSA less than 10, and a low number of positive systematic cores, but it's not defined what is the low number, and it's quite hard to make this definition because everybody is doing different techniques of biopsy. So the number of cores or of positive cores also correlates with the different technique that we do. If we just doing 10 biopsies, of course, we have probably less positive cores compared to somebody who's doing 20 biopsies. So it really has to be decided together with the patient. And in the prior study, which was a big study on active surveillance, the inclusion criteria were also Gleason grade 6 to 7, and the part or the proportion of Gleason score 7 should be less than 50%. And also the clinical stage should be less or equal CT2. I think the German S3 guidelines are quite practical because I don't know if that's correct, but they give us at least a clear advice. And patients with the following parameters should not receive active monitoring. And those are the patients with a PSA greater than 15 and a Gleason score of 3 plus 4 with an unfavorable risk profile. Those are patients with cribriform or intraductal growth. And the proportion of the Gleason pattern 4 should not be bigger than 30%. And I think there we see how important the MRI is and how important the initial diagnosis is to make a good decision for this patient, because the proportion of Gleason score 4 really has a big influence on our clinical decision. So how do we proceed with those patients that we decided to put on active surveillance? And I think this is also a really good recommendation of the EAU guidelines from 2025. So do not perform confirmatory biopsies if a patient has had upfront MRI and targeted biopsies. So I think in Germany right now, it really is the standard that all the patients are getting an MRI before biopsy. So we do not have to repeat the MRI, of course. I think this recommendation is quite clear. Base the strategy on active surveillance on a strict follow-up protocol, including PSA, digital rectal examination, and repeated biopsies. And they give us exact recommendation every 2 to 3 years for 10 years. And the PSA value should be monitored at least every 6 months. But this is a strong recommendation. We can exclude patients with a low risk PCA, a stable MRI, and a stable low PSA density of less than 0.15 from repeat biopsies when MRI is repeated before repeat biopsies. So I think what the EAU does, they put the MRI up front in the follow-up of those active surveillance patients. So if we have a stable MRI and a low risk criteria, then we do not have to perform a repeated biopsy, which is of course very good for the patient. And of course, we have to perform an MRI and repeat the biopsy if the PSA is rising. And they include here the doubling time, which is quite interesting because all the other recommendation of other guidelines, the doubling time is not included. And this doubling time should not be less than 3 years. I think it's quite practical to have a clear recommendation. And I think here the EAU guidelines are outstanding because they really give us a clear recommendation for those patients, because especially in our times, the diagnosis is changing so fast, it's quite hard. So we need really up-to-date guidelines to look for, and the EAU guidelines are the most updated or the frequently updated guidelines that we have right now. So this is why I really commend it in those patients for active surveillance. So in summary, decision to perform a prostate biopsy is according to the risk assessment, mainly based on PSA density, rectal examination, family history, and of course the MP MRI result. Biopsy should be combined, and we should perform an MRI ultrasound fusion and a systematic biopsy. And the standard should be the transperineal approach with the support of artificial intelligence and without antibiotic prophylaxis, and the active surveillance standard for low risk and possible for selected intermediate risk tumors. It should be standard, and I think we should include the active surveillance more and more in those patients. And I think a Gleason score of less than 30% is a safe border where we can decide for active surveillance. So thank you very much. This is the perspective of the urologist. Thank you so much.
Many thanks, Professor Hinz, for your excellent presentation and for sharing your insights and, of course, your perspective as for guiding us through the patient pathway. I see we are in good time, so we have 10 minutes for questions, and I think we can now officially begin the Q&A session. And maybe let me start with the first question, and this is maybe a question for you, Stefan. So when no prostate imaging is available, systematic biopsy with 12 cores is necessary. When MR or TRUS is available with high-resolution images, can we reduce the number of biopsy samples when we already see the abnormality on MR or TRUS? And for targeted biopsy, the question is, how many samples are enough? I know you elaborated a little bit on this, but this is the first question that came into the chat.
Yeah, thank you very much. I think it is, of course, dependent on the MRI that we have. If we have a Pirates 4 or 5 lesion, we have seen that it is highly predictive of a clinical significant tumor. So if we have a clear lesion in the MRI, of course, it's nice to spare some systematic biopsies. And we are doing it right now if it's really totally clear that we just biopsy the target area. And but I think altogether and for all the outpatient clinics, the recommendation to spare the systematic biopsy is not the right. We're not at the right point right now. So I would still recommend to do the systematic biopsies. And as I told you before, we're not doing more than 10 biopsies because with 10 biopsies, I think we can really get a good view of the whole prostate. So we're sparing the areas where we do targeted biopsies. And so we do not need a systematic biopsy right next to a target biopsy. So therefore, we just need 10 biopsies. I think this is not recommended in guidelines right now. It's just the technique, how we do it. So I think if you're not sure, then do 2 or 3 biopsies more. I think it's safe to do this way, but I also think it's safe to do it the way we do it right now.
Thank you very much. Maybe this brings me to a follow-up question exactly for the systematic biopsy that came in. Would you omit systematic biopsy if prostate cancer screening would be available in Germany and you were sure that after 2 years the patient would be re-invited for screening if the biopsy was negative?
I mean, like I said, I would do the MRI first, and depending on the results of the MRI and also depending on the clinical parameters of the patient with the PSA density and with the development of the PSA, is the PSA rising, yes or no? Digital rectal examination, of course, is also important, but not necessary if the MRI is totally stable and the PSA value is also stable. So if we have a low risk here and a stable MRI, I would not recommend the biopsy.
Maybe if I'm allowed to add to this topic, I think the screening of prostate cancer is very, very early, with including MRI. So it is a very dynamic field, mainly investigated by large studies. And one study, for example, the Probe study, also highlights the importance that we adjust the PSA cutoff values to really recommend MRI in the first place or not. So screening is a very different setting, and what Stefan already highlighted is that we have to take into account the outcome and the clinical correlation. So what is the benefit of really diagnosing a very small, low-grade prostate cancer? All those questions has to be discussed in the future. So screening is a very hot topic and difficult to find an answer for it at the current moment, when to use which modality, which approach and when to re-invite patients. I think this is very difficult, but again, I agree with Stefan that I think MRI is defining the pathway, if biopsy or not, and re-inviting patients.
Thanks, Charlie. Maybe a question on this one, because the Prokomb trial is very convincing. And does that mean that MRI is the standard for prostate cancer diagnosis?
Well, as also Stefan highlighted the importance of the MRI for decision making, the research and data show for it that MRI should be implemented in the diagnosis and should be performed before every biopsy. But unfortunately, money rules the world. So at the current stage in Germany, the insurance does not cover MRI in every case before a biopsy. So it is difficult to also get an MRI for our patients, even though they have suspected prostate cancer. And this is also true for a lot of other countries. So currently, it is not the standard that every man gets an MRI, but it should be the standard. And I'm convinced the guidelines has already confirmed that it should be the standard, but I hope the insurance policies will change towards recommending and covering MRI as well.
Many thanks, Charlie.
Okay. Can I jump in with a question for Stefan? And you discussed the topic of transrectal and transperineal biopsy with the benefit of avoiding, for example, the antibiotics and so on. But would you have a favorable approach depending on the location of the lesion? So if the lesion is more in the ventral aspect, more at the base or more dorsally, would you adjust your decision, or would you always go for transperineal biopsy?
Well, it's a good question, because in the start of the transperineal approach, we did have some difficulties with the ventral tumors. So we recommended at the beginning to do those tumors, especially with the transrectal approach. But getting more and more used to the technique, of course, it's not a problem anymore. So the bone, the os pubis, which might be in the way, it's not really a problem. It's more like the angle you need to get to these locations. And of course, it's possible. Like I said before, we're not using transperineal approach anymore at all. So transrectal, sorry, yeah, the transrectal approach. So I think it's all a matter of how used are you to the technique, and how good do you feel with the technique? Of course, if you're not feeling good and you're not feeling safe, then you should proceed, especially in those special cases, with a transrectal approach. I think you can still do it. It's reasonable, because the results of the transperineal approach is not much better compared to the transrectal results. But we can spare the antibiotic, and that's the main reason why we think it's the better approach.
And maybe to add on the biopsy approach, in the literature it's also discussed to go for a targeted biopsy and saturation biopsy around the targeted lesion, compared to performing a standardized systematic biopsy covering the contralateral lobe. Do you have an opinion on that, or experience with focus saturation? We already touched the base or the topic with how many cores do you need. There's also retrospective analyses that at least 3 targeted biopsies normally should be performed, but saturation might also be a topic in the future in the combination with AI, as you mentioned, for example.
Yeah, I think that's not quite clear where we're going to. The saturation is one method that makes the targeted biopsy a little bit safer, I think. But still, we do find, I think, with a percentage of 5%, significant lesions outside the field. So even if we're doing the saturation, as I showed you before, the patient, we might not have hit this tumor with just the targeted biopsy. So I think it still is more safe to use the systematic approach. at least adapted systematic approach. That's how we do it. And what we also use is the artificial intelligence. It really helps us in patients with a Pirate score of 1 to 3 to define regions of interest. And we do show more significant tumors in those patients with the use of artificial intelligence. I think we're getting better here every year. So we're just about to renew the software, because the more information we get, the better gets the artificial intelligence. And I think this is probably the way to go in the future to spare the systematic biopsy.
Thank you, Sean.
I also have a question for you, Charlie. So we discussed the availability of the 3 Tesla of the MRI, and I think the colleagues in Europe and all over the world might have the problems that they do not have all 3 Tesla machines. Do you still think we do need a 3 Tesla machine to get a good MRI?
Yeah, thank you. That's a good question. So the standardized imaging is really crucial. So you have to have good image quality, which is also highlighted by the PyQual score, which has been introduced a few years back and is now becoming more and more importantly. What it means, it gives you a score on your report, reporting how good the image quality was on your score and giving you confidence in your decision making. But this is mainly not depending on the machine itself. Well, it is depending on the machine itself, but not if it's 3 Tesla or 1.5 Tesla. So you can get really good images also using a 1.5 Tesla, but you have to have your image parameters for the T2 weighted, the B value, all those imaging criteria and parameters has to be adjusted and in a good format, and there are recommendations how to achieve that. Crucial is the B value, is the high calculate B value, as I have mentioned. But the high Tesla scanners are an advancement, of course, but they are not essential. You can get also good image quality if you have a 1.5 Tesla, but the patient preparation and the image parameters have to be close to optimal. Well, yeah. And when we discuss about prostate cancer diagnosis, I always like those discussions because it is a very dynamic field. But what I sometimes miss is that we radiologists and urologists talk about the accuracy of diagnosis measured on the reference of clinically significant prostate cancer. It mainly is always about the rate and percentage of clinically significant prostate cancer, but the reference is defined by the pathologist, and he's seldom in those discussions because the grading of the histology is also challenging, and there's a great variation on the center and the experience of the pathologist how consistent this reference is. So I think for everyone who is involved in prostate cancer diagnosis, it's really important that he participates in multidisciplinary tumor meetings to get a feedback from the pathologist and urologist to have a dynamic discussion, because the radiologist can be wrong with the lesion, the urologist might miss the lesion, but also the pathologist might have a variation in his reporting. So I think the discussion is really important, and the feedback, constant feedback loop to really assure quality and feedback. And I think, and I know that at the Vivantes, at the clinic where Stefan is working, that this loop is very good and functioning, and high quality diagnosis is assured.
Wonderful. Charlie, Stefan, thank you so much. I really enjoyed your presentation and also the discussion that we had now. It was very interactive, very insightful. I hope our participants also enjoyed the presentation and the discussion as much as I did. And I hope that you found the information that has been shared today enlightening and also beneficial. So thanks again for participating and for the engagement in our prostate webinar. I really appreciate your time and also the interest in advancing prostate cancer care. And I hope we see each other in future events. And I wish all of you a wonderful rest of the day, a good evening, and a good start into the day. So take care, and hopefully see you soon, everyone. Bye-bye.
Bye. Thank you, Laura, for the invitation, and see you soon, Stefan, hopefully.
Thank you. Thank you for the invitation. See you.
Bye.